So without further ado, I'm going to introduce Professor Amir Kazory from the University of Florida, who is going to speak to us on worsening kidney function in acute heart failure. Welcome.
Good morning, everyone. Is there advancer here or?
Is there a little?
Okay, perfect. Thank you. Excellent. So, good morning, everyone. It's always a pleasure to be here in San Diego. I'd like to thank Professor Mehta and the organizing committee for their kind invitation. Today, I am being asked to talk about worsening kidney function in acute heart failure, which most of us refer to as cardiorenal syndrome. These are my disclosures. None of them is related directly to this talk. So today, I'm going to provide you with some updates in the field of cardiorenal medicine. And I want then to use these elements to see if we can reconstruct cardiorenal syndrome in 2025. As you remember, in the late 1990s and early 2000s, there were lots of papers coming out about cardiorenal syndrome. The problem was that each of them had its own definition, and that made the comparison of the results very difficult. Until 2008, I don't know if Professor Anko is here or not this morning, he came up with his colleagues with a definition that remained the cornerstone of this syndrome. Basically, they said, this is the disorder of the heart or the kidney when an acute or chronic dysfunction will induce acute or chronic dysfunction in the other organ. So basically, it had two elements to it. One was chronology-based, and it was directional for the first time, actually. But I think the most important part of this syndrome was that they started to, I guess it has stopped working. Oh, now it's working. Perfect. It gave us some subtypes. I think that was the most attractive part of this landmark paper and made it very popular in a way that you see, up until 2007, 2008, there were a number of papers coming out. After that paper, there was a major sharp increase in the number of papers as a marker or surrogate marker for interest in the field. When people saw this success, they decided, hey, let's make it better, let's improve it. How did they decide to do it? By adding to it, to make it more comprehensive. Basically saying that, let's go beyond the heart and the kidney, let's add vessels, let's add other stuff. So I mentioned two of these efforts. There have been several efforts. Two of them that are more important and more recent, I just mentioned to you. One is in 2003, Professor Zoccali, again from Italy. He came up and said, let's move away from cardiorenal syndrome and talk about chronic cardiovascular and kidney disorder. What do they mean by it? They say you have a cardiovascular component, you have a kidney component, and whoever has both of them has this syndrome. A second one that was more important came from American Heart Association. It was in November 2023, actually. They came up and said, let's take cardiovascular, let's take kidney, then add to it the metabolic risk factors. And what they meant by metabolic risk factors was the usual thing, obesity and diabetes. So basically, CKM syndrome, cardiovascular kidney metabolic syndrome, includes these four elements. Just like any AHA paper, they came up with beautiful, colorful pictures. And a few weeks later, they came up with their calculators. It sounds familiar, right? They do all the time the same way. So the calculator is here. It can be used. It's called Prevent, and it is helpful in some ways. It gives you the estimated risk. This is 10-year risk. They also have 30-year risk. The important part about this calculator is that for the first time, compared to previous ones, it also includes heart failure separately compared to atherosclerotic cardiovascular disease. So what are my comments on these? I think they are good. The problem with them is that they're all about comorbidities and chronic conditions. You know, they remind me of metabolic syndrome. How much do we talk about it these days? How helpful was that? So It's not bad, but at the same time, I think it has limited applicability to the patient that you and I might see in the hospital. So if we think that cardiorenal syndrome may need to be trimmed, how can we do it? Over the next few slides, I give you some updates that have been there since 2008 landmark paper and see if we can use these elements and reconstruct the definition. Number one thing I want to say, this concept is from me. I think we should resist the temptation of being comprehensive. That's a trap. Add this, add that. It's good, but you lose precision, in my opinion. So I would remove staging, subtypes, and all those, and I just keep cardiorenal syndrome. Very simple. Simple guy, simple definition. A syndrome where acute heart failure is followed by or associated with acute kidney injury. Let's keep this as our starting point. Next one is this AKI, even a real AKI. For this audience, I think you know the answer. Over the years here in this meeting, we have talked about it several times, different ways. I just put for you this Markometras paper in 2012, more than 13 years ago. What it told us is that if you have worsening renal function with congestion, obviously the outcome will be bad. But if you have worsening renal function, you are not congested, actually it is as if you don't have worsening renal function. So the primary driver of outcome is not the kidney dysfunction, it's your congestion. Several studies came out after this. I just thought that I would use a meta-analysis for that with accepted inherent problems of meta-analysis. This is 13 studies, more than 8,000 patients from Steve Coca. So what do they say? They say, hey, if you have acute decompensated heart failure and you have worsening renal function, let me make it correct. Yes, all acute decompensated heart failure patients. If you have worsening renal function, you have a 71% increase in your mortality. That's what it says. Then, if you go with acute decompensated heart failure without this decongestion, let's remove the double negation and say with congestion. So acute heart failure and congestion, the mortality is really bad, 2.3 times more than somebody who doesn't have it. But if you remove the congestion, meaning acute decompensated heart failure without decongestion, the importance of renal dysfunction just is going away. Again and again, congestion is the driver of outcomes, not the kidney dysfunction. So, Professor Ronco and I, a few years ago, we decided we are going to call this rise in serum creatinine rather than worsening renal function or AKI or all other names that you see here, because it is purely descriptive and it doesn't convey any implication of prognosis or mechanistic approach. It just tells you what you see. Another point about cardiorenal medicine is about the urine. Does it count for anything? And I bet this is not the urine that you all have in mind now. I'm not talking about urine output. I'm talking about what is inside the urine. In this study, patients come with acute heart failure. I start them on loop diuretics. I put them on a 2 gram per day of sodium restriction. Then I look at their urine output, the urine sodium, and I do a balance study to see how much sodium do they lose, okay? Not surprisingly to you, if somebody has a positive sodium balance, is in a bad shape compared to somebody who has a negative sodium balance. I don't think it is surprising to you. But what might surprise you is the next one. It tells you that if I have a positive sodium balance, even if I have fluid loss, I am in a bad shape. It's what is inside the urine counts, not the urine itself. And the problem with loop diuretics, what is it? We all know. Those who have been in the ICUs know it very well. First day you have good response, then it goes away very fast. In this study, this is urine output. Urine output first day great, second day and third day comes down. When they adjusted for the dose of loop diuretics, they say, oh no, actually it looked bad, but it seems that it is not that bad for urine output. It stays the same, adjusted for the dose of loop diuretics. What about urine sodium? Urine sodium, first day good, second and third day bad. Let's adjust this one for the dose of loop diuretics. This one is bad. First day, I had good natriuretic response, but not the second or third day, despite my diuretic dose being the same. That's why we are, from the left side, you see the conventional way of looking at the fluid-based monitoring of patients with acute heart failure. We are looking at urine output, weight, intake output. We are shying away from that. We are going towards early urine sodium guided approaches. And when I say early, I mean as early as 2 hours. 2 hours after I give somebody diuretic, I check the urine sodium and I decide if I need to change my strategy or not. Interestingly enough, this is the basis for definition of diuretic resistance. 4 years ago, if you had asked me, so what's the definition of diuretic resistance? I didn't have a good answer. I could tell you a few things that have been said, but two different people will have two different approaches. Now, we say it's a backward definition. If I give somebody an optimal dose of loop diuretic, and this is defined, if I give somebody an optimal dose of loop diuretic and I check their urine sodium, it is less than 50, they are presenting with diuretic resistance. So what about improvement in renal function? The name goes with it, improvement. How should I feel about it? Well, this is the topic of our workshop tomorrow, so I just put one slide for it here, and I just want to tell you that as opposed to what we might think, improvement in renal function, when you see a serum creatinine is coming down, despite you giving loop diuretics at high dose, it might not be a good sign. In patients with heart failure, you see on top SRF is a stable renal function, followed by worsening renal function, and look at the down thing, improvement in renal function. So the survival might not be as good as we think. And if you are interested in knowing why, tomorrow we'll talk about it. Well, what about cystatin C and biomarkers? Can they help? I have to say, data is mixed. I'm not sure yet, but so far it doesn't seem to have a major role in patients with heart failure. You see here, the serum creatinine and cystatin C, as they go up, the three biomarkers that they checked, they're just flat lines. There is no correlation between the serum creatinine or cystatin C with these, okay? And the important part is that even at larger changes, my creatinine goes up by 1, but by my biomarker does not move much. So are they helpful? At least in this study, they were not. And something that might even be more troubling is this. What they saw in this study is that if your biomarkers come down, or your cystatin or creatinine go down, the survival is worse, actually. So for now, we are not sure. And I have to add another paper that just came a few months ago here. This is actually from Professor Murray's group. They looked at more than 20 biomarkers in patients with acute heart failure. They couldn't find a good correlation with worsening renal function, except for the top you see, serum galectin-3. Galectin-3. Is it really helpful at long run or not? This is something that time will tell us. Okay. I gave you a number of updates, and now it's time for me to keep my promise and offer you a reconstruction of the definition of cardiorenal syndrome. In 2008, we said type 1 cardiorenal syndrome is acute heart failure and worsening renal function. The next decade, it was all about congestion and decongestion. Now we said that acute heart failure plus rising serum creatinine plus a congestion that is persistent, is not going away despite our efforts. I think now we can say cardiorenal syndrome is acute heart failure plus any change in serum creatinine, worsening or improving, okay? Or diuretic resistance, for which you and I, we have a definition. Basically, urine sodium plays a major role these days in prognostication of these patients. Then I put there that renal biomarkers and cystatin C, this is something that the future will tell us if they will be helpful or not. And with this, I would like to thank you for your attention.
Thank you very much for this very nice overview. We have room for one question, if there's someone. I wondered when you were talking on first item was the definition of cardiorenal, and then later on you clearly showed that creatinine increase actually is a good thing in these patients regarding outcome. So should we also look for an alternative in these patients for the classic KDIGO definition, which is based on increase of serum creatinine? Maybe this increase of serum creatinine is good, and so we should have an alternative definition?
Well, I call these data, I have to say, I call them BAD, meaning best available data. Based on what we know, I think that, I don't know if I would aim for worsening renal function, but what I think that in 2025 is that if I am decongesting a patient, the decongestion is going well and serum creatinine goes up, I'm not going to be scared. I will continue that, at least this.
That's an important message, I think. Thank you very much.
Thank you.